So you got exams in May, isn't it?
Yeah, 13th. Are you going as an examiner or?
No, if I'm examiner, I can't do this
Okay.
because there is a conflict of interest.
Okay.
I can teach only my trainees if I'm an examiner.
All right. Okay.
Okay, Erikas, we are online now.
Yep.
And I don't think anybody has joined. I think two people watching now. You are not watching, isn't it?
No, I can. If you wish, I
You
can.
prefer don't to watch,
Yeah.
prefer not to watch.
Yeah.
Okay,
There
so
might be a
that
bit of delay as well. Yeah.
you have to behave as if you are in the exam. So your full focus is only on the Zoom discussion. That's it. Okay, maybe you can watch it later.
Sure.
We'll start the scenario in 3 minutes time. We'll start the scenario. Good morning, everyone. It's 10 o'clock on 12th of February 2021. This platform is for the trainees preparing for FRCS Urology Viva, which happens both in UK and also in various international centers. Welcome for those who are taking part in the YouTube live and taking part as observers. You all have a WhatsApp group, so if there is any questions arising at any time, please feel free to send the questions in the WhatsApp group. It will be answered after the scenario. I will introduce the trainee now, and let's start.
Good morning, Ananda, and thank you for having this the training session. I'm one of the trainees from the Thames Valley region, and I'm due to sit for my Viva in 3 months' time in May this year. And I'm happy that this session is recorded for the use of the trainees in future.
Very good. So, as we all know, the FRCS consists of 8 tables. Every table has 2 scenarios, 10 minutes each. Today, we are going to start the discussions on BPE table. BPE is a very wide topic. It may be like initial evaluation of a person coming with urinary symptom, medical management, surgical management, and now a well-evolved, minimally invasive therapies. So various scenarios possible in BPE. Apart from these, the other scenarios parallelly possible are like patient presenting with acute retention, high pressure chronic retention, patients who had TRP presenting with bleeding, etc. Apart from the BPE table, BPE related scenarios you may come across even in emergency table, where it could be a post TRP patient with bleeding or sepsis who needs some urgent intervention. Patients can also, I mean, these scenarios can also be discussed in the infection table, where a patient can present with sepsis and you may end up the BPE is the reason for the sepsis. So BPE is a very wide topic. It's a very basic topic also. Today we will start a scenario and discuss. This is the first time we are doing this platform, and at one point, maybe after a few weeks, I will do a complete session on how to approach this exam. Ideally, that should be done first, but we want to start and test this platform and then go ahead. Possibly after today, we may have to do the BP part 2 continuation session in next few weeks time, and then we will complete the tables one by one. Till April 1st, we will have a very friendly discussion. The scenarios can go up to 40 minutes. It's not a very exam pattern scenarios. After the 40 minutes, the trainees who are sending me the questions in WhatsApp group, all the questions will be answered. So the whole session will last for exactly 60 minutes. Unfortunately, those who are watching in YouTube, there is no way you can take part in YouTube chat, I think. One way it's good. Don't need to look into two platforms for the questions and clarifications. I can just look into the WhatsApp group, and if there is any questions, I will happy to clarify as we go. After April 1st, our scenarios will be exactly 10 minutes, keeping up with the exam pattern. There won't be any feedbacks during the 10 minutes. After full 10 minutes presentation, we will assess the candidates' presentation, how they can improve it, how they can work on the three main forms of knowledge, communication, and application of the knowledge in practice. Okay, let's start the scenario.
Yeah, I'm
You are
ready.
doing a clinic. It's a normal general outpatient clinic. A 73-year-old male was referred by GP due to difficulty in passing urine and getting up 2-3 times in the night to pass urine, and he's quite having a disturbed sleep due to that. The patient presented to your outpatient clinic in a very good pre-COVID era. What will you do?
Okay. Once he comes into my room, I would start taking a focus history, and followed by the examination. In the history, mainly, I would like to know about his difficulty in passing urine, mainly the low urinary tract symptoms, particularly giving attention to the voiding symptoms and storage symptoms. In the voiding symptoms, I would ask whether he has any incomplete emptying, intermittent voiding, and strain to pass water, and mainly his flow, and whether he has terminal dribbling, and so on. And as far as the storage symptoms are concerned, I would ask whether he has a frequency, urgency, and nocturia. You said that he's having 2 to 3 times a night. I would like a little bit more about that, and I would ask how disturbed it is, whether he wakes up to pass urine, or he pass urine because he wake up. Because we see in some patients, they wake up for some other reason, and then they go to pass urine. And also in general, I would ask how this is interfering his lifestyle, how much he is bothered. The good tool here is to give him a IPSS the questionnaire to be filled, so we can get an objective idea about his symptom scores, predominant symptoms, whether it's voiding or storage, and also his quality of life affected by these symptoms. Move on to that, I would ask about his past medical history, especially any urological history in the past, whether he had these symptoms, how long he has these symptoms, whether he has been taken any treatment, whether he has got any help from the GP or any other urologist in town, and also about his other medical history like diabetes, blood pressure, any neurological diseases, to get a common idea, and any surgery he had in the past, especially the urological surgeries or other surgeries in general. I would also would like to ask him about his drug history in general, and also specifically whether he has taken any anticholinergics, any blood thinning medication, and so on. And to complete, I would ask him about his social history. What is he doing? What was his job? Whether he was smoking, and and also if he is still active, his lifestyle, and so on. And after that, I would move on to the examination. Mainly, I would do a general examination to see his well-being. Especially, I would look for any facial swelling, ankle swelling, which can give a clue whether he has any cardiac or renal disease. And specifically in the abdominal examination, I would look for any palatable kidneys or a palpable bladder. Move on to the genital examination. I would see whether his external meatus is okay, any obvious deformity in the penis, and the scrotal examination. I would complete my examination with the digital rectal examination to look for the size of the prostate, to have a feel of the prostate, to see if there is hard or any nodules are suspicious. And also, I will complete with the neurological focus neurological examination. Mainly when I do the DRE, I could feel the anal tone, and also by the way he walks into the clinic, I can generally get an idea about his neurology. And moving on, after the history and examination, investigation comes into play. In our practice, if they come to a special low unit tract symptom clinic, usually they have a flow rate and then urine dipstick done, but I don't know how he is ready for that. If the facility is available, I would ask for a flow rate if the patient is bladder is full. Otherwise, even a simple bladder scan might be helpful if it is available. It all depends on the availability what you have. Um, if the facility is not available, I would ask for a basic blood test if that is not done by GP and mentioned in the referral letter. Specifically, I would get a basic full blood count and the renal functions, and the PSA as well, since he is having low unit tract symptoms.
Okay, that's a good comprehensive answer. Let us dissect few things from the starting. Regarding the IPSS score, could you explain it a little bit, and what is the role for IPSS score? What are all the components? How you can apply it to quantify a patient's symptoms?
Yeah, IPSS score is called as International Prostate Symptom Score. It has 7 questions related to patient's urination, and 1 question related to patient's quality of life. It has 4 components of the voiding symptoms, like incomplete emptying, intermittency, and weak stream, and straining. 3 parts for the irritative symptoms, or storage symptoms rather: frequency, urgency, and nocturia. And a common question about the quality of life, scoring from 1 to 6. 1 is more pleased, and 6 is terrible. This is the quality of life score is different from what it was seen in the AU symptom score. So that is in general. So the applications wise, first is when you diagnose a patient, you can get an idea how their symptoms trouble them. And this is mainly talks about within last 1 month, how much they have the symptom. They score from 1 to 5. The minimum score is 1 or 0, and then maximum score is 35. With the scoring system, we can rate the severity of the symptom which the patient has. For example, like if it is 1 to 7, we call it mild LUTS, low unit tract symptoms. 8 to 19 is moderate, and more than 20 up to 35 is severe symptoms. So as far as the application is concerned, like when diagnosis, you can know how severe their symptoms is, which is important for us to plan the management. For example, if you see the nice guidelines, they say the mild symptoms can be managed conservatively. When it goes to moderate and severe system, you have to think of intervening mainly medically if they present for the first time. And on follow-up after a particular treatment, either it could be a medical treatment or surgical treatment, you can follow up with the patient with the repeat IPS score. We can objectively show the patient, or that whether your treatment has worked. So this is reproducible and validated questionnaire in many languages over the world. So that's a very good tool to assess the patient's initial presentation and to monitor the treatment, and that's how it can be applied.
Good. That's a very good explanation. So IPSS is quite good, not only as a baseline, it will also help us to quantify patient symptoms after medical management, after surgical management, in the follow-up. So we have something to compare the patient symptoms. The one thing you can mention it as disadvantages, it's very, very subjective. So if somebody with the same symptoms, if you can clone them into two men, and if they give the symptom score to two men, somebody may come with a score of 12, somebody may come with score of 18. So it is very subjective, but the validity of the scoring system improves if you have multiple scoring systems in the follow-up, which shows a good increasing or improving pattern. So in that way, IPS is good.
And another criticism that the incontinence, you can't assess incontinence from IPS. That is one of the drawbacks with the IPS, especially if they have severe the storage symptoms and have incontinence. There's no way to assess that in IPSS, I think.
And also the scoring system is not specific to BPE, because the things can happen due to urethral stricture, can happen due to detritus or hypocontractility, and so many factors can cause. It's more of a quantification score for urinary symptoms rather than specific for BPE. That's another thing. In your history, I'm happy with your comprehensive history. So the history should be like concentrating on patients' primary presentation, expanding it, and knowing as much as possible by using any scoring system based upon the symptom presentation. The few main things which I wish you should add. Number one, your answer is quite nice and elaborate. So that will consume a lot of time. Be very mindful. In the exam, you need to progress very quickly. As I said, till 1st of April, we are going to do it in a very relaxed fashion. So you will talk a lot, and time permits, I will talk much more. But in actual exam, you may have to completely make it into a very clear bullet points. And if you start preparing in bullet points, you will not miss any key points. And I am looking for only the key points. And I was told even the examiners got only the key points in front of them as something like a quantification key. So the main thing which you could have added is, for example, patient smoking history and erectile dysfunction history, because these things will have good impact in further treating the patient and also the treatment outcomes. And the main thing, since the patient, I said, has got nighttime frequency, we can ask about his caffeinated drink history, his fluid history after, especially in the evening time, and also the alcohol history. I mean, your answers are correct, but you may be coming out of the table very confidently, but the examiner may be expecting these things, and if those things were not ticked, you will still get a good pass mark. But I wish BPE is such a good subject to score very, very high marks so that you can balance out if you have any bad table. Okay. So the main thing to concentrate is erectile dysfunction. It may be quite normal, but just to run through it, and smoking history, caffeinated drinks history, etc. And coming to the examination, I'm glad you have included the physical general examination to rule out renal failure. It's very important, and it's a good learning point for other trainees. And I'm happy with your genital examination, digital examination, which is quite common and very straightforward. I mean, the one other thing which I prefer female candidates and also definitely male candidates to add is using a chaperone. I mean, it's sometimes more of like an exercise. I'm sure a lot of male candidates may not be using it in real time, but it's a good habit. And I will say use the word chaperone whenever you are examining man, woman, others, kids, any category for all the 8 tables. Because if I teach like, okay, make sure you say chaperone whenever you see women or children, then it's very difficult to remember and keep it in practice. But if you just say chaperone whenever you see the patient, it's a very easy way not to forget in other tables also. So my advice is to use chaperone for any examination, and use the terms like after obtaining verbal consent. These are all more of like a posh exam techniques, and this will differentiate you from other trainees, and the examiner will feel, oh, he's not only good in knowledge, not only good in practicing whatever, but he's also able to present it in a slightly different manner. And that really gives examiner a good happy feeling that, oh, examining with a chaperone after obtaining a verbal consent. So, and don't use these terms restrictively. Use these terms widely in all the 8 tables so that it becomes like part and parcel of your common life. And from today till you pass the exams, if possible, throughout your life, even in the normal clinic letters to your GP, you can just say, after obtaining verbal consent, with help in the presence of a chaperone, I examine the patient, my examination findings. So if you start doing it in the clinic letters, that will be a very nice revision tool, and you will never miss it in the exam. And this should be your lifetime practice. If you practice this in the lifetime, you will tomorrow become a good teacher also. Okay,
Yeah. Okay.
good. And the last other thing is urine dipstick contrometry. I'm sure urine dipstick should be possible in most of the hospitals. So don't make it as something which, if available, so urine dipstick is a must. In fact, you can say, I will ask the patient to give a urine dipstick when he is waiting to see me, so that you can see the patient with a urine dipstick, which is a quite preliminary investigation. And Euroflowmetry, it's nice if you include, because some units have the one-stop LUTS clinic, so that will give you the option to do
Yeah.
Euroflowmetry in the same visit. Till this point, you have not brought in any evidence. It's a nice practice to bring some articles or guidelines or something on and off. And I wish people to bring evidences at least 3 to 4 times in the whole 10 minutes. And till this point, you haven't brought. Maybe you may be waiting for the medical
I,
management something to start to bring
I
you.
told I told once about nice.
Yeah,
Uh, yeah, but nothing else I could find that I can go bring in. So I'm waiting for the when we move on to the what do
medical
you think?
management.
Any evidence that I can bring now? I think I bought nice.
Nice is a good evidence,
Yeah,
but
I
the
bought.
thing is like, you can say nice nicely in all the 8 tables, but I want you to be more specific. So what nice guidelines?
Mm, yeah, I
So
think.
it is 2015 lower urinary tract symptoms in men NICE guidelines. Okay,
Okay.
being
Okay.
very specific, the
Okay.
guidelines was released initially in 2010 and then later updated in 2015. It's almost time for the NICE to update. NICE is updating the individual guidelines. Say, for example, Eurolift, Resume, ITIND. It's working on individual guidelines. Maybe once all the individual guidelines were finalized, NICE may be coming out with a good overall LUTS guidelines, maybe I will say 2022.
Okay.
And yeah, so to go for, if you even don't have a facility, at least being in a UK candidate, you can say that you will do Euroflowmetry. I'm going to discuss few things about Euroflowmetry. What precautions you will tell the patient when they are going for Euroflowmetry?
Um, I would say like they have to have an adequate amount of urine filled in the bladder. So I would ask him to drink a coffee or water and then tell us whether when he's ready for the uroflowmetry. And also I would tell him that he has to pee on the pot as he normally does. Yeah.
Okay, good. And I'm going to show you a Euroflowmetry picture. Just try to read that for me. Can you see that better?
Yes. Yeah. So he has a prolonged voiding with an obstructive pattern. This is not the normal pattern, not the normal bell-shaped curve that we see. And his Qmax is also, I think, maybe around 5 or less, depending milliliter per second, depending on that. Yeah.
Okay, yeah. Okay, that's good. So, I mean, you can say it's 5 with more confidence. Maybe I will send you this picture later in WhatsApp, um, because there is at least the picture is not very clear. To be frank, in exam, sometimes the pictures won't be absolutely brilliant. You will be having such pictures only. I was told nowadays people use iPad, so the pictures are much better than whatever 10 years before. And so there is one line in the top which is showing like 15
Right.
ml line, and then the lowermost is the 5 ml line. And as you said, at least 2-3 times the patient's curve reached 5 ml and never crossed it, so that shows that Qmax of 5. And the residual urine for this patient is 300 ml, and his voided volume is 650 ml. So what you infer from this uroflow?
Yeah, so his functional bladder capacity is from that okay, from the trace, it's he has obstructed voiding. The uh, the voided volume is 650. That shows his functional bladder capacity is 650 milliliter, and the post voidal residual of 300 milliliter. So that means he's voiding only 350 milliliter. So he's voiding at least half of what he has. At this point, I would like to do a ultrasound scan for the upper tract to make sure that he doesn't have upper tract damage, hydronephrosis, and also to look for a renal function test to see the baseline creatinine and eGFR.
What is the NICE guidelines advice on doing renal parameters test and ultrasound?
If there is a hydronephrosis, you should do. Otherwise, you don't need to.
You can say the patient has hydronephrosis only after ultrasound, isn't it? So,
Yes.
what is the NICE guidelines advice on doing ultrasound and renal parameters blood test?
Yeah. Yeah. If there is a if there is a impairment in the eGFR, then you have to go for ultrasound scan. That's a nice
Okay.
guide. Yes, yeah.
Okay. In other ways, the NICE guidelines 2015 says if the patient has any signs of renal failure in examination, which you slightly touched upon during the examination, like puffiness of face or pityriatic edema or the obvious signs of renal failure. If there is anything, there is a role for
Yeah.
ultrasound and also the renal parameters blood test. Of course, we all do quite routinely blood test. By being an exam going student, at least we should be quite confident to know what is the NICE stance on the blood test performance. And also, if the physical examination shows distended bladder, that's a good, important evidence to go for ultrasound and blood test. Okay, let us assume that this patient has no physical signs of renal failure. His abdominal examination haven't showed any distended bladder, so we are not going for any ultrasound or blood test as of now. So, what is your advice? The patient is quite bothered. His IPS score is 22. His bothersome score is 6 out of 6.
Okay, 6 out of 6. Okay. Do we know anything about his prostate size at this point?
Yeah, examination wise, you felt the prostate is 80 cc. It is smooth, no evidence of any suspiciousness. There is no neurological problems.
Okay. PSA. Do we have any PSA from the GP's letter?
No.
Now PSA. Okay, fine. So he has severe symptoms according to the IPSS score, and also the quality of life score is 6 out of 6. That is terrible according to him. And I know that his PSA is 80. So at this point, with the significant post-voidal residual volume of 300 milliliter, I would like to start a treatment for this. I would counsel him that based on what I told earlier, and then I would like to start him on a medical management for him, based on the evidence that we have from the NICE guideline 2015, and also the papers of MTOPS study and combat study. The combination treatment is best for him since his PSA is since his prostate is more than 80 cc. A combination treatment of alpha blocker and a 5-alpha reductase inhibitor is useful for him. So I would start him on both tamsulosin and finasteride in my practice.
Okay. And regarding his symptoms, can you dissect the symptoms a little bit more so that you will decide about which one to choose?
Yes, that's a good one. Yeah, basically, if the IPSS is 22, that means he will definitely have some elements of significant irritative symptoms as well. So I will go through what is the predominant symptom, and if it is obstructive symptoms, yes, I would start. Yeah, it's a bit tricky here, which is very predominant symptoms. But from the flow rate, we know that his flow is definitely reduced. So I'm not in a rush to start on anticholinergics for his storage symptoms because of his post-void residual volume of 300. So what I will do is I'll first start the combination therapy for obstructive symptoms, and I will review him in ideally then according to the NICE guidelines to 2015 is in 6 weeks, but for the practical reasons sometimes it might go a little longer than that. So I will review him in my clinic from 6 weeks to 3 months time, and then I will do a repeat uroflow with the post-viral residual symptoms, residual volume, and I'll reassess his symptoms. And if the post-viral residual has come down and if he's still complaining of significant irritative symptoms, I might add anticholinergic to treat that component.
Okay, so how we can address this question is always when you're explaining the IPSS score and if the examiner gives you the score, immediately tell the examiner that in total IPSS score is very important. As you correctly said, we can divide the patients into mild, moderate, and severe category. Quality of life score is very important. That shows how much patient is bothered by the symptoms. A retired person with a set of symptoms will be less bothered compared to a person who is working as a lorry driver. We all come across the different groups of patients. So that's why the quality of bothersome symptom is very important. So this patient definitely presented with some evidence of nighttime frequency. So what I prefer is before jumping into the medications, you can ask a little bit about catching up his smoking, his caffeinated drink history and personal history so that you can pick those lifestyle changes.
Yeah.
If the patient is coming in the mild IPS score category, as per the NICE guidelines 2015, you may have to stop there because there is a role for watchful waiting and lifestyle changes and review the patients in 6 weeks or 3 months time. NICE guidelines mentions in few places 6 weeks follow-up, like for example, after lifestyle change advice, after alpha blockers, after anticholinergics, 6 weeks. But we all know in NHS, 3 months is practical.
Yeah.
So it's very important to bring the practicality also because the examiner should have a confidence. Yes, you know what is given in the literature, and also you know what is practically feasible in the general practice as far as the UK NHS is concerned. So but this patient is slightly more advanced. His IPS score is very high. It's coming in the severe category. It's very bothered, and prostate is quite large. And your uroflowmetry clearly showed a nice obstructive pattern with a very good amount of residual urine. So he is in the verge of more progression compared to others. So one main advice is when you are using the word obstructive, be very careful. Never use the term obstructive to define a symptom.
Yeah, it's
Symptoms
voiding.
should be, yeah, symptoms should be voiding. At least once you said
Voiding.
obstructive symptom.
Yeah.
But when you're explaining a uroflowmetry, it's quite funny. You need to use the word obstructive pattern. So just be a little bit clear. It all comes with the practice.
Yeah.
How you can say patient or patient person with LUTS has more chances of progression? What are all the factors you will look at?
Yeah, we have evidence for this from Olmsted County study. There are
Okay.
certain features that have been identified. For example, like if the age is more than 70, that is one of the strong indicator that they can go into complications like acute urinary retention, and PSA more than 1.4, prostate size more than 30 gram, and IPSS more than 7 and Qmax less than 12 milliliter per second. So these are the factors which can give us a clue whether this patient is going to get complications.
Very good. And apart from the prostate size, you can use the PSA value also.
Yeah,
What is the
1.4. 1.4.
1 point? Yeah, even though the value may not be available at that point of discussion, you can say the theoretical 1.4 value. Apart from Olmsted County study, you can also use the placebo arm of
The
various studies
yeah.
like MTOP, COMBODAT, all the studies. COMBODAT don't have a placebo arm. Don't say COMBODAT. MTOP, PLS, all
Yes,
other
yes.
studies with placebo arm, so that can be used.
Yeah.
Okay. Now let us.
I
Yeah.
have a question here. Those five factors, is it purely from Olmsted or is it a collective from all these studies or placebo arms as well? I had a doubt today.
It's collective from
Correct.
various
Okay,
studies.
fine.
And
Okay.
for example, the PSA 1.4 is from a different study.
Okay.
Prostate size cutoff is from a different study. There is another study known as the VA study in US, known as Veterans Administrative Study. So what
Mhm.
is happening is in US, all the veterans who got retired, they have got a kind of an insurance package, and they all enrolled, and they're all very meticulously monitored for blood pressure, sugar level, HbA1c, IPSS, PSA, everything, because they're all veterans. They have served the country, so it's very important to make sure that they are healthy. So this Veterans Administrative Group has created a huge database, which is a very nice database to look into if you want to study a normal population.
Okay.
But we need to be very mindful. End of the day, they're all veterans, so they may be having a better active exercise, and the lifestyle may be quite what can I say, well trained compared to a normal office going guy or a very sedentary work
Yeah.
pattern guy. So those are all the disadvantages of the veteran administrative study. But veteran administrative is got very high number. For those trainees who are joined in YouTube, I hope you guys have good audio coverage. As I said, there is no chat facility available in YouTube, so post questions only in WhatsApp. I can see some questions. Thank you for that. We will address that maybe in another 10 minutes time before the closing of the session. Now, how are you going to treat this further? So when treating this patient further, even if the patient is a definite medical management category, is not a patient for conservative management or watchful waiting because of various factors. His post-word residue is high, his Qmax is very poor, IPS score is quite high, DRE showed a 80 cc prostate. There are very high risk factors for progression for him.
Yeah.
Even then, there is nothing wrong in spending a minute to explain to the patient that he needs to have some lifestyle changes also, because everything adds into a good outcome. There is no point in giving a patient a combination of, as you said, 5 alpha blockers and finasteride, for example, and then patient is still drinking jugs of caffeinated tea, isn't it?
Yeah. Yeah.
So even the patient is fit for medication or indicated for medication, just touch upon the lifestyle changes, especially for his nocturia, cutting down the fluids after 5 p.m. in the evening, avoiding heavy alcoholic drinks in the evening, switching to decaffeinated drinks, keeping well hydrated, avoiding constipation. These factors try to mention in your GP letters from today, because it's very important to have this very easy to talk. The examiner should feel you're talking like how you're talking to a patient, not like a prepared talk. Okay,
Yeah.
good. So you are selecting some medications. You have advised him lifestyle changes. How are you going to choose the medications?
Yeah. As I mentioned, like
That you mentioned.
yeah, the tamsulosin and finasteride as combination
Why?
therapy.
Why the combination of tamsulosin and finasteride?
Yeah, we have evidence from the combination treatment, the MTOPS and uh, combat trial that the combination treatment is better than the individual drugs to prevent the progression of the disease. And also we have evidence from plus trial and the other trials, the alpha reductase inhibitor blocker arm, that is they will prevent the occurrence of acute retention of urine, especially the plus trial. It shows 57% reduction, and also the need for surgery, TURP, in future by 55%. So definitely we have the benefit of the 5 alpha reductase inhibitor, and more than that, this is PSA, the prostate size is 80 cc, and with all the other reason for the other risk factor of progression, so he'll be benefited by both, because we have evidence from NICE guideline 2015. If the PSA is more than 1.4 or prostate size is more than 30 gram, the combination treatment is advised. So based on that evidence, I would go for combination treatment on him.
Very good. I will always advise the exam going students to use as much of studies as possible in two tables. One is this BPE table, the other one is prostate cancer tables. There is no real reason to bring any studies in any other tables like bladder cancer, testicular cancer, renal cancer. But if you can bring, that really adds quite good value to your answers. The best thing is, even if you don't have some studies, at least you can bring in something like EAU 2021 guidelines, because I think by the time you guys are going to the exam, the 2021 guidelines should be out, and there should not be any major change between 2020 and 2021.
Mhm.
Then the other thing is, you have mentioned good studies. I accept that. But which study looked into the combination of tamsulosin and finasteride?
Tamsulosin is combat study. Combat.
No, no.
The
What studied in a combat
MTOP,
study?
MTOPS is doxazosin and finasteride. Oh,
Mhm.
yeah, you're right. Yeah, combat is tamsulosin and oh,
Combat is tamsulosin and dutasteride. Okay.
butosterone. Sorry, yeah.
So the studies you quoted are correct, but none of the studies have ever studied tamsulosin and finasteride combination.
Yes.
Yes, there are some very, very small studies studied this combination. So when you're mentioning this, it's nice if you say that I prefer this combination, even though there is no direct study to prove this combination. But we know as a generic, alpha blockers and 5-alpha reductase inhibitors combination is quite good, something like that.
Yeah, and
These are,
you can quote plus is for finasteride, and you can
yes.
talk about the cost as well. Like if you can, like, cost is the finasteride is much cheaper than dutasteride, so that's why I prefer this combination or something like that. Do you agree?
Regarding finasteride and dutasteride, I mean, nobody will go so much into detail. I'm taking you into the detail because it's a very important subject. It's nice to have a very strong base on LUTS evaluation, medical management before jumping into surgical management. Between finasteride and dutasteride, yes, cost is favoring finasteride, and the pharmacological difference between finasteride and dutasteride is
Yeah, it's dutasteride is block alpha reductase 1 and 2. Finasteride blocks 2, which is predominantly in the prostate. The clinically there's no difference, but pharmacologically the finasteride blocks 70% of the receptors, and the dutasteride blocks almost 90% of the receptors. But the clinically the effect is same.
perfect. So all the more reason, less cost in finasteride. Clinically, there is no advantage in using dutasteride, even though pharmacologically it is just a dual receptor blocker. So that's why finasteride is well chosen. Regarding alpha blockers, why you choose tamsulosin? Why not prazosin, sildosin, alprazosin?
Yeah, tamsulosin is alpha 1 A selective, highly selective with less side effects, and silodosin is not available in the UK. So that's the reason. So the side effect of hypotension and all is less in tamsulosin compared to the other drugs.
Again, you can bring like widespread availability and also receptor specific, which makes the side effects more tolerable.
Yeah.
Okay. And so I'm quite happy for you to start this patient on lifestyle changes. That is very important for his nocturia. And also you can keep him on the dual drugs because of the presentation of the enlarged prostate, which is almost 80 cc now. So how are you going to review this patient? You are starting him on tamsulosin and finasteride. How will you explain the drugs, and when are you going to see him again?
Okay. I will tell him the mode of action of the drug. Mainly, the tamsulosin will act on the prostate and the urethra to relax the prostate, so that will give a symptomatic improvement, usually immediately within 24 hours. But as far as the finasteride, I would tell him that it will shrink the size of the prostate, basically around 30% in 1 year time, based on plus study. And I would tell him that it might take some time to start kicking off. So I would tell him that to continue that at least for 6 weeks to 3 months before he gets before he sees a real effect as far as the finasteride is concerned. And also I would review him in 6 weeks to 3 months, as I told. And if he's doing well, we can continue that, and we have an option after 6 months to stop tamsulosin if he's okay with that, because 6 months usually the finasteride start acting, and then slowly we can try stopping tamsulosin and see if he's okay with that, so he can be on a single medication, or else if he's happy we can continue both.
Okay, you haven't explained any side effects of the medications yet.
Sorry, yeah. So the tamsulosin, the main side effect I would warn him is a first dose hypotension, even though it's not seen in most of the, in all the patients. So I would tell him that to take it at night time just before the bed, and to sit initially at least until he gets used to the medication. And the other side effect is retrograde ejaculations, but I don't know how much it will affect a man in 73. But still, I would tell him that he might have ejaculation retrogradely, and if he pass urine immediately after an ejaculation, he might notice a bit of turbidity in his urine, and not to worry that. And I would ensure him that if he sees that, that means the drug is acting. As far as the finasteride is concerned, the common side effects is reduced libido, and in some patients they come with reduced erection as well. So I will warn about these side effects.
Okay, good. Any other medicines, or I mean, any other blood test you will do now, or you just want to review the patient later?
As I told you, I would like to have a baseline PSA because of the symptoms. Yeah, that's it. And depending on the PSA, I will plan my management based on the value.
Regarding PSA, you have to sell it in a slightly different manner. You need to say something like, there is evidence to prove that if the PSA is more than 1.4, the chances of progression is very high. So I wish to have a baseline PSA. That is first reason. Second reason, you are starting the patient on finasteride. We all know that finasteride will decrease PSA.
Yeah.
And we will miss actually what is the patient's baseline PSA is. It's nice to have a baseline PSA. All the rest of the PSA in his future life will be having the impact of finasteride. So that is a good evidence to do finasteride. I mean, a good evidence to do PSA test. Till this point, there is no evidence to do ultrasound or blood test. Okay.
Yeah.
So try to play very carefully. Don't bring too much of what you're doing clinically into the exam, because some examiners are quite good in asking you why, and there is no answer for you to bail out. But if the examiner,
with the post void of 300, would you at least do a renal function at this point?
yeah, there is a rule there. So maybe you can say such a high post-void residue and the high chance for progression. I wish to know the baseline blood test, and yeah, nothing wrong in it.
Yeah. Okay.
So when are you going to review the patient?
Yeah, in 3 months in the clinic, because of the practical issues and logistic issues. So I would review in
What
3
will you
months.
do in 3 months' time?
I would assess him symptomatically, and I would like to have a repeat IPSS questionnaire filled, and also a repeat uroflowmetry and a post-viral residual to see the improvement of the medical treatment which I gave. And also I would revisit whether he has changed his lifestyle in terms of caffeine intake and alcohol intake and smoking. If he was having that before, I would see that. And also I would have given a frequency volume chart to be filled to bring it to the next clinic. So I will review that as well.
Okay. So what is the rule for frequency volume chart?
It's a simple chart. You can get an idea about his fluid intake and voiding. So one thing is you can see whether he's drinking a lot of fluid with the type of fluid he drinks, and also the amount of urine he voids. So that will give us a bladder capacity, the functional capacity as well. And also the frequency, you can see how frequent he's voiding in the daytime and in the nighttime. And also you can measure the volume to see whether he has isolated nocturnal polyuria, or it's a part of the nocturia that he has based on his symptoms. So these things I can get from the frequency volume chart.
Very good. So you should bring in the nocturnal polyuria ratio and other
Yeah.
things.
So if he's voiding more than 1/3, he's 70 plus. So if he's voiding more than 1/3 of his daily urine output during the night while he sleeps, that means that he is having nocturnal polyuria. So my management would be a little bit different from what I do now.
Okay, well done. We'll stop it now because we have crossed almost 45 minutes now. There are a few questions available in the WhatsApp for me to discuss, which I will discuss now. Of course, feel free to add any questions if you have for the scenarios which we discussed till now. In the next class, we will pick up from where we have left and we will travel with this patient. Possibly, we can use the same patient to discuss what happens if the medical treatment fails, what is the role for surgery, what is the role for minimally invasive surgeries, and we can even discuss to the level of post-surgery side effects like incontinence, how to treat everything. So we can discuss the same scenario into two further sessions and finish the whole BPH spectrum. Okay.
Okay. Yeah. Yeah.
Yeah. And let me just address some of the nice, interesting questions from the WhatsApp chat. Um, can we say we'll give the patient IPSS questionnaire while we are waiting to see us? It's a fantastic method to save the time. So the one different way you can make it much more look better is you can, when you're wetting your GP's referral letters, if the patient is definite, straightforward, voiding or mixed LUTS or storage LUTS, you can, when the appointment department is sending an appointment form, they can attach an IPSS with that, and they can even attach a frequency volume chart with that. And there are various questionnaire patient information leaflet. The patient can go through the leaflet and then go through the IPSS questionnaire and fill the form before coming even to the clinic. That will be more realistic because the patient is filling the IPSS questionnaire and frequency volume chart in the home environment rather than when he's waiting to see the patient. That is the answer for whether IPSS questionnaire can be given before we see us. Double voiding is a good technique for PVR more than 300. That's why I wish a good time to be spent on lifestyle modifications, avoiding caffeinated drinks, alcohol, this kind of double voiding, timed voiding, and making sure that maybe in the night also they need to differentiate whether they are going to toilet just because they are woke up, or is it the real urge to pass urine is waking up. That's very important to know. Lot of elderly people, they go to the toilet just because they are woke up, maybe
Yeah.
because
Yeah.
of
Yeah.
noise, yeah, dog barking or any other noise. So that's won't be really addressed by your medications, so that should be addressed by a kind of a different speciality of how to improve the quality of the sleep. And yes, it's correct. More than 300 ml PVR, and also that's a good indication for upper tract imaging because we need to make sure that there is no um, pressure transferred to the upper tracts, resulting in a kind of evolving high pressure chronic retention situation. And as nice 2015 says, cystoscopy is also indicated if the patient has profound symptoms. Yes, of course, because there is a good possibility it could be something like a urethral stricture, and we may be looking exactly in the opposite direction. So I projected this patient into a very, very complex high IPSS and high PVR so that we'll discuss all the options possible. And yeah, nocturnal polyuria can be helped by conservative management and Nocudrina. If you are answering in the exam, don't use the trade names. Anything like Nocudrina or
What
anything,
is
you
that?
need to say, pardon?
What is that? I don't know. Is it desmopressin?
Yeah, maybe desmopressin. To be frank, I don't know. It could be a drug which reduces the urine production in the night time. But use the medications pharmacology name like desmopressin, and also you should be able to tell the dose, whether 100 micrograms, 200 micrograms can be taken up, 400 micrograms, and whether you're doing it like a patch or a nasal spray. So just be careful with that. And that finishes. I will give my overall feedback. Overall feedback, you have studied well. There is no doubt in that. I can only catch you in very, very small areas here and there. You can see that. But once you travel with me, discussing few scenarios more, I'm sure you will be able to answer those things also. And you can, you should not allow me to talk. So everything should be tick box. And let us do this in a very relaxed manner as we are doing it now. maybe for the February and March. From April onwards, we should be able to train ourselves how we can. This is one scenario. This is one 10-minute scenario. So how we can put so much of things into just into the 10 minutes, how we can talk in a bullet point manner, and how we can improve this further. That's the plan from the 1st of April. And we should finish all the 8 tables. We should take variety of scenarios. Like for example, BPH, if we are taking one more scenario, we should finish in the next class the BPE. There won't be any further BPE. When we are revisiting the 8 tables again near the exam, possibly we will be discussing a little bit more like high pressure chronic tension, or something like post TUR syndrome, something different, not the normal thing. So that's why all the classes are very important. This simple BPE discussion, we will have no time to discuss before the exam. So every scenario is done and dusted. So make sure those who are participating in YouTube to complete the full BPE syllabus, so that next time we will discuss only the surgical management of BPE. And if you travel in pace with us, I will make sure that you guys are finishing the portions well in time with appropriate time for revision.
Yeah, that's great.
Okay,
Can
guys?
I have some questions? Can I ask them, please?
Yeah, please.
Yeah, one thing is when someone has high IPSS, say more than 20, 25, the severe symptoms, and their quality of life is 3 to 4. Are you still want to start treatment, or you can wait? Because NICE says like you start treatment moderate and severe IPSS, the LUTS. So do you go by the patient's symptom burden at this time, or just go by the the evaluation?
No, if the patient is symptomatic, you should start the treatment. When you're reading the NICE guidelines, be a little bit careful, especially the 2015 guidelines. A
Mhm.
good chunk of 2015 guidelines, the early part is for GPs.
Yeah.
Okay, so they're all for primary care. And then it discusses about when to refer the patient to a tertiary care. Just be very careful. Read that, understand it, but that's not for you. You will be reading a little bit the later part, because the early part, there are some terms like don't do flowmetry for the patient presenting for the first time with urinary symptoms.
Yeah.
Those things don't apply to us.
Yeah. Yeah.
So you should be able to do the flowmetry and the urine dipstick and IPSS. These are all very, very basic must for LUTS evaluation. So coming to the exact answer, I will say if the patient is very symptomatic, you should treat. There is no point in leaving the patient conservatively. Only if the patient is having very mild symptoms. If the patient says, doctor, I just get up once in the night, it's not really disturbing me, but I'm a bit worried whether something bad is happening. Otherwise, in the daytime, I'm passing urine well, I have no problem with my stream. It's very rare for you to have such a patient in the normal practice, because these patients will be vetted by the GP itself.
Yeah.
But in case if you come across this patient, I don't think it's a correct practice to start this patient on anticholinergic or alpha blocker. We should strongly advise the patient lifestyle changes, cutting down the fluids after 5 p.m., see how it goes on, and we should rely on medications only if needed. Okay.
And
So
when we mention,
mostly,
yeah.
just to complete, mostly in exam, you will be ending up starting the patient on medicines. They won't discuss just conservative management in exams.
Okay. When you talk about studies, do you want to know in depth with the percentage and all, either for this or for the surgical treatment of BPH or whatever? How much a percentage it improves the symptoms? How much Qmax is improving? Do you want to know that details, or just the final results of the study? What do you think personally?
Yeah, I will say try to get as much possible for BPH and prostate cancer, because those are the only two tables where there is a heavy reliance on the studies.
Okay.
In
Okay.
my experience, many people read so much of studies, and they do so much of hard work, notes, revision, the notes, everything. But on the day, they may not be able to reproduce the studies, and obviously they will pass. That's not a problem at all. Passing is not at all an issue, but they will feel bad. Oh my God, if I'm not using the studies and if I can't reproduce it, what is the point in spending so much of time? I remember when I went to the exams, we studied as a group, like how you guys are studying. And one of my study buddy, just 2 days before the exam, or even one day, I believe, He asked me, what is ABC study? I said, what? ABC study? It's advanced bladder cancer study. It's there in EAU guidelines, the main guidelines. But these are all absolutely waste of time. Okay. So what I will advise is know about some studies, because when you're saying that you're going to give tamsulosin and finasteride, even if the examiner is not asking, try to give more weightage by saying that I am starting this combination because of the studies like MTOP studies and combat study, but I am aware that none of the studies studied the exact combination of tamsulosin and finasteride, but I'm just following the pharmacological group of drugs, so that examiner, you won't allow the examiner to ask you that you are quoting a study, but you are starting a medication, but those don't match. Okay, only very few examiners will catch you like that. And coming to the values, for example, the PLESS study for finasteride, it has shown like almost 53% reduction in RP reduction rate, 53% reduction in need for surgery, or 50%. So those things you can approximate. You can say half of the patient doesn't require surgery, half of the patient doesn't progress to retention. So you can approximate, but instead of saying half, if you say 50, 51, it doesn't matter. And end of the day, examiner is also not having a Campbell textbook of urology in front of him. The examiner has got only few key points, and they may have some values. And if it is 54, and if you say 53, to be frank, it doesn't matter. If every answer is correct answer, as long as it's approximate. So try to have something like that, because it's a very nice thing to say. Finasteride reduces the retention and need for surgery in 50% of the people. So those are all very, very good values. And later, when we go to the surgical outcomes for minimal invasive surgery for BPH, for example, um, Eurolift, Resume, TURP, HOLUP. When you're comparing, the only way you will compare is how much the Qmax, how much the IPSS were changed. And those things, again, it's nice if you have a kind of value to that, so that you will know, okay, Eurolift and Resume reduced the IPSS to a certain level, but HOLUP reduced it to much, much better level. So that's a nice thing to compare. Okay.
Yeah.
Okay, good. Well done. We are just 3 minutes to finish. If there are no further questions, I'm quite happy to complete it.
If you
And
have,
in the
if,
WhatsApp group,
if you have time, the role of tadalafil, because the tadalafil in the medical treatment, we have conflicting evidence, even isn't it? Previously they said we can use, and now latest NICE say that you can't use for treating low urotract symptoms. But I don't know whether when someone has both LUTS and the ED, whether you can use it, because it's not very clearly given in NICE. NICE says only about it's not recommended to use as a treatment for LUTS. What is your take on that?
Yeah, I think it's nice if you keep yourself updated and keep yourself to the latest NICE guidelines.
Okay.
So the outcomes are: number one, tadalafil once daily 5 milligram should not be used as a monotherapy for LUTS. That's it. Number one. Number two, if a patient has only LUTS and no erectile dysfunction, there is no place for tadalafil. Okay. And so most commonly, what you will do is you have a patient with erectile dysfunction, and the patient also has some degree of LUTS. They're all quite ideal to start tadalafil 5 milligram monotherapy once daily. Beware, it's very costly compared to the other drugs, tamsulosin and finasteride, what we are discussing. So that's one of the things why NICE may have taken a back step in not promoting it very well. And if the patient is already on tamsulosin and finasteride, and if the patient develops erectile dysfunction, it could be due to finasteride itself. It could be maybe the ejaculatory loss, which is resulting in high score. So just be very careful in that. But certainly, once you start doing a lot of specialized LUTS clinics, you will come across patients who are very, very obsessive about their erectile function, but at the same time, very afraid to take tamsulosin and finasteride because of the sexual side effects. So tadalafil 5 milligram is very useful as monotherapy in a very selective patients. Okay.
All right.
Yeah. And so now the next scenario is almost out. The same patient you're going to see in 3 months' time. and the patient is going to fail your treatment, and we are going to discuss how are you going to treat the patient who medically failed, and slowly I will take you into various surgical managements.
Yeah. Okay.
Okay, good.
Good.
And please post your feedbacks to WhatsApp. This is the first time I think ever anybody has done this Viva practice in a YouTube live, and it's a good experience for me, but it went very well.
Thank you. Thank you very
Good.
much.
Have a good day, everyone.
Thanks, Anand. Thank you.